Welcome back. Hopefully we're good. Everything's looking good my side. Let's see if we've got some people in live as well, so that's good. Let's just say hello. Good morning. It would help if I could spell. There we go. Hopefully we are good. I'll just wait for a message to come through, and then we'll get going. Excuse me. Hey, there we go. Thank goodness for that. The anticipation. Good morning. Morning. Good morning. Happy Monday to you. Good. Right. Let's get you going. So this is the last Learn Anatomy Online for August. I think. Let me just quickly check my diary. Hi, Mo. And as you can tell by my nasal tones, I'm ready for a holiday. Yeah, 1st of September we'll be back. Yes. Yeah, no problem. Can you go over Haglands as missed last week? Yeah, no problem. We can do that. Let me go back on some of those. Okay. Let's just go back to gastroc. Okay. So, what you can have with the insertion of gastroc, so right down here, it's something that can happen. It's a bit like Osgood Schlatters, where you get a pull on the enthesis, which is the attachment point on the bone, and so surrounding the bone you've got periosteum. And where the tendon attaches into that periosteum, it can pull. That creates a kind of chemical reaction in the area via something called mechanotransduction. So where you're basically trying to convert muscle energy into movement, and there's a whole cascade of enzyme reactions and chemical reactions that go on to make an area stronger. So if you've never done any running, jumping and stuff like that before, then when you first start doing it, if you do too much, the tissue isn't ready for it. So you have this big increase in enzyme activity, which then leads to changes and degradation to the tissue. The way that the body responds to that, especially if it's for a prolonged period of time, it starts to lay down calcific deposits, and basically they'll turn into bone. And you can get a in kids you can have something called Sever's disease, where it's again that's probably more like Osgood Schlatters really, where it's pulling on the tibial tuberosity in Osgood's, but pulling on the calcaneus where the gastrocnemius attaches, and that constant pull and that irritation. So if there's a sudden increase in activity, it will cause inflammation and pain in the area. If you manage it well, then it should subside. But if it's not managed that well, then it can become a permanent lump, and it's a bit like plantar fascia as well. So you get a bone spur growing on that area of the heel on the calcaneus, just there. So where the gastrocnemius and soleus attach, well, the Achilles tendon attaches. So that is what's going on with it. Hopefully that answers your question. Missed last week, talk about, yeah, hopefully that answers the question. If you've got any like specific things with a patient or something like that, then give me a shout. Literally had an inquiry yesterday. As a friend of ours where their son is suffering from SEBAs, and I was teaching a course, face-to-face course, and we had a couple of podiatrists on the course, so that was quite useful. I was able to pick their brains. And with SEBAs, we just the recommendation was to offload the tendon for a bit. Obviously reduce activity, ibuprofen, paracetamol to help with the pain and the swelling, and then a heel raise to shorten the tendon, so it just offloads the tendon for a bit. But obviously that's not to do forever. You need to gradually bring it back down to normal again. But that's like the immediate advice. Yeah. Oh, okay, yes, yeah, I remember now. So client is addicted to high rocks and the lump is so big she can't wear normal shoes now. Yeah. Advised last year to calm things down when it was a small lump, but never listened. Now for, yeah, unfortunately that's it. I mean, high rocks is a great example of overload, and if it's not progressively done, then your body adapts by laying down bone. The muscle can't cope, the tendon can't cope, so it sticks bone there, and yeah, and once it's there, that's it, and yeah, you're done. Like you say, surgery's the option. I have seen that in ultra runners as well, and we've had to cut a bit of the back of their shoe off, so that their heel can fit in it. Yeah, been advised stretching. That's interesting for that kind of condition. Yeah, I'd question that, definitely, because you're just going to pull on the insertion point even more. I would suggest. But yeah, that seems like strange advice. I'd have a look into that advice. Really, there must be some papers or guidance on helping to manage Haglunds. So yeah, I'll have a look and I'll pop it in our Facebook group after today. Cool. Hopefully that's been useful. I don't know sometimes when I witter on whether it's actually useful information or not. There you go. We had a good one with Natalie actually, and yeah, but it'd be not good. Okay, cool, no problem. Yeah, so we'll see how that ends up, and then maybe talk about that, because that's obviously a private patient. So yeah, I'm just giving some advice on that one. So yeah, we'll see how that turns out. Right, let's get you going then. So this is where we finished off. We were looking at that superior posterior compartment, superficial posterior compartment, sorry, and the deep posterior compartment as the last couple of bits of the leg. And now we're going to move down into the foot. So this is where we finished off with a bit of a summary for everything, where the muscles go, where the nerves go. So you've got a bit of time off now to do a bit of a deep dive into the nerves and the blood supply for the foot and ankle, ready for the 1st of September. We'll see how you go with that. Yeah, so these were the movements available from those compartments as well. So they're all coloured differently, and the colours are followed through all the way through the slides, so that you know which ones are which. So that's all of those. Just get rid of that. And then we're up to here. So these are the last muscles we're going to look at for the foot. Hopefully be able to cover all these today, fingers crossed. And then we can start afresh on the nerves and the blood supply when I come back. So the intrinsic foot muscles, these are the small muscles in the foot itself. So not to do with the ankle, doesn't affect plantar flexion, dorsiflexion. It's mainly the movement of the toes, the metatarsals, all around that region. Okay, so you'll hear of excuse me, intrinsic foot exercises. I've just ordered something from a company called the Foot Collective, and they do all these little like scrunchy balls and a balance beam made of cork, which for me it absolutely kills my feet. But I just need to build up a tolerance to it. I have to wear shoes on it, which kind of defeats the object. So I'm gonna have to get some barefoot shoes to protect my sole of my foot. I'm a bit of a wuss when it comes to my feet, and get Mick taken out of me by my family walking along a pebble beach. I can't do that, no chance. It hurts way too much. It's like I've been shot, and I need to wear shoes. And so walking on one of those cork things, it just it hurts too much. But yeah, they've got these like scrunchy things like hacky sack balls, got bands for your toes and all that kind of stuff. So that's basically, these are the muscles that all of that stuff helps with. And so you should be able to do the movements because there are muscles there to be able to do it. But if your feet are screwed up in shoes all day, then you just don't get the opportunity to work these muscles. So you can train them because they are there. So we've got splitting into different areas. So we've got the big toe specifically, and anything with the big toe specifically is called a hallux or hallucis muscle. The little toe specifically is the digiti minimi. So same with the little finger, but in the thumb, in the hand it's the pollucis, in the foot it's the hallux or hallucis. So yeah, very very similar anatomy with the hands and the feet in terms of the names. And then specifically for the toes, any muscle that's got digitorum in the name is to do with your digits. So that's not the big toe, that's the other four toes. Okay, so you've got muscles go into those, muscles go into the big toe specifically, muscles go into the little toe specifically. So again, very similar to the hand. So I'm going to have a look at all of those today. So these are the big toe ones. Some of them we've got videos for, some of them we haven't. So I'll show you them all, and then we'll have a look at the videos that I've got, so that you can have a look at them. So this one is, you've heard of flexor hallucis longus, FHL. This is flexor hallucis brevis. So longus obviously means long, brevis means short, and this is the brevis. So it's the short one. Doesn't go to the end of the toe, but comes into that first phalanx just there. So the metatarsal phalangeal joint around that kind of area there, and then we've got attachments into the midfoot around here. So where flexor hallucis came from higher up, so flexor hallucis helped with movements of the ankle because of where it starts and where it finishes. This doesn't cross the talocrural joint. It doesn't cross that talus and the tibia and fibula. So the one that brings about dorsiflexion, plantarflexion. So this will have no effect on that movement, but you can see where it goes from and to. It will specifically flex that big toe. Okay, so we've got plantar surfaces of the cuboid, lateral cuneiform bones, tendons of tibialis posterior, and then attaches onto the proximal phalanx of the great toe, and it flexes the toe. That's all it does. And as we start to add these layers on, I think it's really important. It's like with everything. When you have pain in an area, it's automatically gone, oh yeah, that's that. So usually with the foot, if there's pain in the sole of the foot, oh, it's plantar fasciitis. That's the problem. And if you think about this kind of area here, where the plantar fascia will sit on top of that, will be around the medial arch. So if the medial arch area is tender, then it might not be the plantar fascia. It could be these structures underneath. Could be the joints as well. We just don't know. So we can't really be that specific. But then when you do your treatment to an area, whether it's manual therapy, whether it's shockwave, laser, whatever it is, acupuncture, whatever it is you do, you will affect all of the structures in that area, and obviously the nervous system in that area too. And then when you do your exercises, they don't just target one muscle, they target all of the intrinsic muscles of the foot, well, depending on which ones you do. So if you're moving the big toe and you're coming up onto your tiptoes, so doing like calf raise type activities, all of those type of treatments, so manual therapy treatments and exercises will work everything. Yeah, so uh, it doesn't change what you do. It just changes the fact that it's may not be plantar fasciitis. That's all. And I think we're starting to go through a process of realizing that we can't be very specific, and in the foot especially. Cool. And then we have got a muscle specifically for abducting your big toe. And look at where that attaches. Yeah, right on that medial calcaneus. So medial process of calcaneal tuberosity. That is the exact point where your plantar fascia attaches as well. Okay, so again, if we do treatment for the heel, and then we give people exercises to strengthen their foot pain usually gets better. Was it the plantar fascia? Maybe it's this. Yeah, maybe it's the abductor hallucis. Now, if you did want to target this specifically, you need to do an exercise that abducts your big toe. That's harder than it sounds. You try and just isolate and abduct your big toe. If you've been stuck in shoes for all of your life, then that's going to be really, really difficult to do. But you can train it because obviously the muscle is there. So if you wanted to add a band onto the toe to specifically target this muscle, you want to get really close to that MTP joint around there, so the metatarsal phalangeal joint. So if you've got it up here near the distal phalanx, that's quite a long lever for that muscle to try and abduct. So if you bring the band a little bit closer to the insertion point or the attachment point, then that'll make it easier to bring about that movement. So you do your right but not your left. There we go. Yeah. So well, that's very good to be able to do just one. Splaying your toes and being able to grip things and grab things. It's you lose it if you don't use it. It's really important for your foot strength. And one of the reasons I think why we get a lot of foot pain. And then obviously if you've got an abductor, we need an adductor as well. So with this one, if you're going to do an exercise here as well, I get it as close to that MTP joint as you can, because that's where the attachment point for the muscle is. And then have a band attaching on the inside of the toe and then out this way. Yeah, so because you want to start with your toe out, so in an abducted position, and then draw the toe inwards to adduct. And again, that would be quite difficult. But if you have a look here, we've got loads of slips of muscle coming across from the other digits, and then the midfoot here as well. Yeah, so that's obviously an important movement if we've got this kind of broad base of attachment sites and this many muscles doing that job. So we've got plantar aspects of the base of second to the fourth metatarsals, tendon of fibularis longus, so it attaches to fibularis longus as well. And then the other attachment is the lateral aspect, the base of the proximal phalanx of the great toe. So that bit there. Okay, so inside. Excuse me. Excuse me. So you had a flexor, brevis, an abductor, and now an adductor. Okay, so we've got pretty much all the movements covered, apart from one. I think we'll do that later. Yeah, we've got an extensor one as well. I haven't got a slide for that. I've got a video for it though. Let me show you this. So, oh, okay, yeah, we'll do it after we do the digits. Yeah, I'll show you that one. Okay, so let's have a look at this one and get rid of that. Hopefully this works. Yes. Don't want that one. Want that one. Okay. So this is flex. Oh, not. Sorry. Want that one. Flexor, abductor, and adductor hallucis. So all three in one hit. Let's go.
I have added filter and adapter, so all three in one hit. Let's go to your shopping list.
Oh, don't you just love that? I'm not going to say her name just in case. Okay, so flexor hallucis brevis, two heads. Adductor hallucis, you've got the one main head and then the slips coming across, and then there's the abductor there. So we'll have a look at these as we kind of tidy these up. So flexor hallucis, they're coming up here, cuboid, lateral cuneiform, and then coming all the way down so we've got two tendons of insertion and over those sesamoid bones. Now, if you haven't seen these before, these can be a bit of a pain as well, quite literally. So sesamoid bone in the big toe. Now, the big toe is really important for propulsion in gait. So walking, running, really important for that. So a lot of load goes through that big toe. So those muscles that move that big toe have to cope with a lot of load. And the way that the muscle, especially the longest muscles, come around the malleoli or through the retinacula, they've got like a pulley system to help increase the efficiency. And this is the other way to increase the efficiency of that flexion of that big toe, and by putting two little sesamoid bones on the undersurface of the foot, and the flexor hallucis brevis will attach onto those before they get to the proximal phalanx, so the end of this phalange here. And what that will do is increase the efficiency of that flexor hallucis brevis, very similarly to the patella with the quads. Okay, so if you don't have a patella, the quads have to work really hard to extend the knee. And if you, obviously, to have a patella there, you need very little effort at all to be able to extend the knee. So this will do the same with the big toe. Okay, so these sesamoid bones are really important. The only problem is we walk on them, and obviously if you're running, jumping, that kind of thing, you can have quite a bit of impact on them. And obviously if the muscles are being worked quite a lot, then we've got a lot of friction over that site as well. So you can have something called sesamoiditis, and you get inflammation of these sesamoid bones, which can be really, really sore. Obviously, podiatrist is expert in dealing with these, but you basically want to offload that particular movement for a little while. And if you've got a chance, you can change the on orthotic in the shoe, so you can provide like a little bit of space for the sesamoids to sit in. Obviously that's podiatry job. So yeah, if they've had it for a long time and it's just not going away, then I definitely refer them off to a podiatrist to help sort that out. But yeah, those little bones there can be a bit of a pain, again quite literally. Just move me out of the way there. Okay, and then there's your flexor hallucis longus tendon over the top. Everything? Oh, no, I was going to say, hopefully that's not everything. So the adductor, we've got different types of heads. We've got that oblique head, and then we've got transverse heads. So these are adducting the big toe. There's the attachment sites, and then we've got attachment sites here as well on the transverse ligament. So plantar plate kind of area. And then, so that's going to attach on the inside of that big toe, just there, look, and on the sesamoid. So again, we've got another attachment point on those sesamoid bones. And then this one's the abductor. So this one coming up from a little bit higher up here. And again, I really think that this is often confused for plantar fasciitis just because of where it is. And then look at that, it's quite a chunky muscle. And then that one will do abduction, so it will abduct the big toe, bring it out to the side. And it will, they all kind of merge together with flexor hallucis brevis. There we go, so we've got flexion of the big toe. And we've got AB and adduction. There we go. So it is very minimal, but you can do it. Yeah. Send in your videos. Actually, that'd be a bit weird. Yeah, I don't want loads of foot videos. People are weird with feet. Okay, keep them to yourselves. Just send me a message. Okay, so fifth toe. So little toe this time. So this is going to have minimi in the name, more likely. Okay, so we've got flexor digiti minimi just here. So this is going to flex the little toe, and that's going to be its only job. So we've got plantar aspect of base of fifth, and then the plantar aspect of the base of the proximal phalanx. All right, so we've got the proximal phalanx down here, and then the base of the fifth just there. Let me show you the rest of these. We've got abductor digiti minimi. So again, you're going to be able to abduct your little toe on its own independently. So this is that foot splay that I was talking about. We should be able to splay our feet, pick something up. Yeah, it's a lot harder than you think. A lot harder than you think. Medial lateral processes of calcaneal tuberosity, but this time we're on the outside, so not near the medial calcaneal tuberosity where plantar fascia problems usually arise from, but we're on the outside. And the plantar aponeurosis, which is the plantar fascia. So it attaches into the plantar fascia as well. And again, undersurface of the foot, if it's more lateral where they're getting the problem, maybe it's an intrinsic foot muscle issue rather than a plantar fascia issue. But again, does it change your treatment? Not too much. We still want them to reduce pain with manual therapy or whatever therapy you choose to use, and then do some exercises to help with muscle strength. Okay, cool. Let's have a look at those. Hopefully get the right videos this time. Digiti minimi, there we go. Okay, let's have a look at this one. So we've got flexor and abductor digiti minimi. And there it is there. Okay, so flex is the digits and it's short, so that hence the name. Or flex is the little digit, sorry, and it's short. And then look at where that comes from there, abductor. Yeah, again, it's quite a big muscle for a really small area, so it's obviously got a really important role. But look at where it attaches on the calcaneus again. So all around that area there, and then down onto the outside of your phalanx, just there. So it's the proximal one. So it's near the joint again. So again, if you're choosing exercises to do to specifically target these areas, then you want the resistance band to be as close to that joint as possible to give yourself a fighting chance, especially if you're just starting out doing those types of movements. I mean, to be fair, just trying to splay your toes is hard enough sometimes. Sometimes a little resistance helps because it kind of you get the movement that you want to try and do when you can feel the resistance there. But yeah, you want it really close to that metatarsal phalangeal joint, because if you do it up a little bit higher, it increases the lever length and then it becomes impossible to do. So yeah, it's a bit harder. Or don't use any band, just apply some hand force just on the outside of the foot, just for you to push into, to just get that feeling of abduction. Okay, cool. So those are your little toes, and then we've got the digits. Let's have a look at these. So we've got flexor digitorum brevis. So we've got a flexor digitorum longus, and this is the short one. And again, it doesn't cross the ankle joint, so it doesn't come back up into the leg. It starts on the calcaneus, and again, look at the attachment. Exactly the same attachment as your plantar fascia again. So we've got muscles coming in from the big toe, the little toe, and the digits, all attaching around this area here. Yeah. So there's quite a lot going on around that heel, and it's why quite commonly now it's just called plantar heel pain. Yeah. So pain in the heel on the undersurface of the foot, rather than plantar fasciitis. So medial process of calcaneal tuberosity and the plantar aponeurosis. So it's attaching into the fascia as well, and then it will come all the way up. Let me just move me out of the way. And it's coming up quite high this time on the phalange. So it's bypassing that metatarsal phalangeal joint. It's going to the bodies of the middle phalanges of the second, third, and fourth little toes, because obviously there are 3 phalanges in the toes. So it's going to the middle ones. So it will bring about some toe movements, but not the very end of the toe. Okay, so flexes, second, third, fourth, and little toes. So all of those, as well as flexor digiti minimi, will do the little toe as well. Okay, so we've got kind of doubling up on that one. Then we've got these ones. You might remember these from the hand. So we've got interosseous muscles in the feet, very, very similar to the ones that are in the hand. Okay, they do exactly the same kind of job. So it's AB and adduction within the, in this case, the metatarsals, but in the hand, the metacarpals. So very, very similar role. So attachment points, metatarsal bones, medial aspect of the body of the metatarsals. And then they'll go to the proximal phalanx of the toes and the extensor expansion of the toes. So it kind of joins onto the top of the toe as well. It will laterally abduct the toes at the metatarsal phalangeal joint and simultaneously will flex the metatarsal phalangeal joints as well. Okay, so we've got a couple of roles with these muscles. And then we've got these ones. I do all of them together because the video covers them all. The lumbricals, again, remember those from the hand. So we've got the same again. Attachment points, tendons of flexor digitorum longus that travels to the toes. Okay, so these are coming, and you can see the direction that these are coming up just onto that proximal area of the proximal phalanx. Okay, so that's the metatarsal phalangeal joint just there. So we're going just above that MTP. So simultaneously we'll flex the metatarsal phalangeal joints and extend the interphalangeal joints of the toes. Yeah, so we've got those, again, those small intricate movements of the metatarsal phalangeal joints. So again, if you're grabbing things, gripping things, so the classic is the you know, when you like try to bring the towel in without, it's a bit weird, but without using the middle part of your foot, you're just using the toes. That's basically what you're doing with these muscles. Those are the ones you're targeting. And then we should have one last one, quadratus plantae. This one, again, look at where it attaches. Yeah, so I've lost count of the muscles now. Maybe 6, 7 that attach onto the calcaneus, exactly where the plantar fascia attaches. Yeah, so whatever you do, whatever you kind of learn from this, if you work in therapy or fitness work, make sure that if someone's got sore feet and everything's been cleared off with like something nasty, something torn, if it's kind of achiness, that kind of thing, get people strengthening their feet. Yeah, because it will definitely help with the majority of problems with the foot. All right, and so all of those intrinsic foot muscle exercises, really, really good for this kind of thing. So action of this one, assist in flexion of the second, third, fourth, and the little toes. Okay, because of its attachment sites, it's a little bit short on this picture. It's actually a little bit longer. So let's go through the toes. So I've only got a couple of videos of these because they're hard areas to dissect. So we've got interosseous muscles of the foot. So I'll have a look at those ones. So here we are. So that's a picture we saw before, and then there's your interosseous. So it basically means in between the bones. So you can see the metatarsals, and then we've got the muscles in between those areas there. Now, within those in between the toes, you've also got nerve and blood vessels. So nerve, spine, blood vessels. And you may have heard of something called a neuroma. And hopefully now you can see why neuromas may occur. Look how tightly packed everything is in here. Yeah, so if you've got irritation on the surrounding the sheath of that nerve and it's not able to glide very well, then it will rub, it will cause irritation, and it will start to swell and it will start to lay down fibrous tissue on the outside of the nerve sheath, and that's what causes a neuroma. Okay, so it's around this very similar area. We'll have a look at it when we go over the nerves. So we've got all these muscles in between the toes. And again, trying to isolate these, you've got no chance in terms of exercise or therapy. So it's whatever you do will help these areas. And there they are there, look. So you can see them flexing that toe. That's a bit creepy, that one. Good, so that's your interosseous muscles, and then the last ones are your lumbricals and the quadratus plantae. So we'll have a look at those. And again, we'll have a look at the extent of this quadratus plantae because it looked a little bit short on that image. So here we go, first metatarsal phalangeal joints, just along here. These are all your lumbricals. It's actually flexor digitorum longus tendon coming through there, which we looked at previously. Lumbricals just underneath that. And then, yeah, I was going to say sometimes this muscle, quadratus plantae, is called flexor accessorius. Sounds like a really weird dinosaur. Okay, so we've got this the calcaneus here, yeah, and your flexor accessorius, or quadratus plantae comes from that calcaneus. So just there and there. And it will attach into the digitorum. Okay, so we've got two muscles there helping to flex the digits and working together. So one coming from above the ankle, one coming from below. That was a good picture of it then. Let me just go back. I'll see if I can pause that right at the right time. Just there. Yeah, this is in the way a little bit, but there's the medial calcaneus, and then there's the quadratus plantae just there. So it's a really chunky muscle again, like right on the undersurface of the heel, filling that arch of the foot, really, really close to the medial border of the plantar fascia. So again, when you're poking and prodding in there and thinking, well, maybe plantar fascia, it could be this as well. And look at where it attaches. It attaches to the digits. So if you pull the toes up, like you would when you're testing the plantar fascia, that's going to tighten as well. So that if you pull those toes up, extend the toes, that's going to stretch that tendon, make all of those muscles really taut. And then you're poking and prodding, you're going, is that where it's sore? You go, well, it must be plantar fascia, because when I do that, that tightens the fascia. It also tightens these. Yeah, so it's not just one bit. It affects everything. Okay, cool. And then the very last thing that I want to show you is this. Let me just get rid of those and those. It should be this. I feel a sneeze coming on. I'll try and stop myself sneezing into the microphone. Okay, so something called the windlass mechanism. And I think we've talked about it a little bit over the last few weeks. But it's to do with what happens with the big toe extension and how important big toe extension is. So when this big toe lifts, it tightens up all of the tissue underneath the foot to create your arch. And what that does is it supinates your foot, which then locks all of the mid-tarsal joints to provide a really rigid foot so that you can push off. Okay, so if your big toe doesn't extend, you don't get the tightening of the tissue underneath, so that can be a problem. And if you can't go into supination, then this won't work either. And what will happen with people who can't extend the big toe and those that can't resupinate is they will start to overload other structures. And it's not a problem unless you rapidly increase your activity levels. So like I was saying before, if you never run before and you decide to do a 10K, you know, that kind of thing will hurt the muscles in your foot, make them really ache. Some of the other structures as well make them really sore. So if everything's done gradually, then these like not normal things will become normal for that person, for that individual. And a classic example of that is Usain Bolt. He was very flat-footed, so his ability to resupinate was really compromised. But he was pretty good at what he did. He got around it. Yeah. So just because someone's got flat feet, it doesn't mean that that's what's causing their problem. Yeah. So if they've got flat feet and they're going, oh yeah, I've been told that it's because of my flat feet that I've got plantar fasciitis, it's actually 50-50, because people with a supinated foot can suffer from plantar fasciitis as well, or plantar heel pain, whatever the problem is. So it is 50-50. The anatomy of the foot is less likely to be an issue. It's the speed at which you introduce a new activity. That's going to be one of the main problems. But most people, this is how your foot works. Okay, so as you go into extension, create the arch in your foot, and that's called the windlass mechanism. So if we have a look at this, like there, so as soon as that big toe goes into extension, we get this arch in the foot. So that's the meant to represent the plantar fascia, and then as you go up onto your big toe, the arch is created. So that supinates the foot, draws the tissue together, and then creates a rigid foot so that you can push off on it. Okay, ideal. Yeah. So that's what we're looking for as a kind of normal foot. That's what most people, the way that they move. But again, people who move perfectly well with this action going on, and you're able to create that windlass effect, they will have foot problems as well. And again, it's usually linked to overloading with a reduced capacity. So it's usually as simple as that. You adjust things, ease off the load, build up the tolerance again, bit of manual therapy, bit of treatment to help with the pain relief, and then gradually it will get better. Okay, usually. Cool. Done. So that's it for this summer. Back 1st of September. Gonna have a look at the nerves and the blood supply of the foot. So yeah, if you want to do a little bit of homework around those, then that's cool. If you have any questions about today, then and you're part of our Facebook group, then please pop them in the Facebook group, and I'm happy to answer those. Otherwise, I will see you in a few weeks' time. Hope you guys have a really good summer. Take care. See you soon.